In the beginning, it was dark. In the late 1800s, healthcare providers basically doled out potions that did nothing. On the positive side, they were usually relatively cheap. Hospitals were a place where people went to die. Healthcare was not universal, not effective, not fast, I guess depending on when you went to the hospital. And patients had a very low level of trust for both doctors and healthcare institutions. But on the positive side, it was pretty affordable. Since healthcare wasn't incredibly effective, there wasn't a great push to make it universal or to help people pay for it. But there were problems back then as well. Insurance companies, which existed during this time period, were actively avoiding writing healthcare policies because of a concept called adverse selection. That is, how do you cover people that are both sick and well, old and young, and still make the whole venture affordable to everybody and profitable for the business? This debate has continued into the modern healthcare arena. In fact, when Obamacare was published, there were two hotly debated topics related to how to combat adverse selection. The first one was the universal mandate. That is, if we make it so everyone has to get health insurance, then that clearly would level the playing field, right? And the other item was preventing insurance companies from not covering people because of pre-existing conditions. People who are already sick are the ones who need health insurance the most, so we need to make sure that they can be covered as well. But you can tell by just looking at the news around you today that these two concepts are incredibly important for how we decide what steps we take to go forward with healthcare in the modern world. Ineffective elixirs and end-of-life care were not very profitable ventures. But luckily, the 1900s came, and they brought germ theory, blood transfusions, penicillin. Suddenly, hospitals had a lot more to do, and more beds to fill. But hospital care was becoming too expensive for many Americans to afford. In the 1920s, Baylor Hospital offered the Dallas Teachers Union a special rate, and the first prepaid health plan was born. This idea later became known as the Blue Cross plans, with cost-plus design. By 1939, 3 million Americans were enrolled, and Blue Cross Blue Shield was rapidly on its way to becoming one of the most respected brands in U.S. history. They were a nonprofit. They offered the same care for the same rate to all Americans, no matter how long their hospital stay, no matter what. No matter what. As far as plan designs go, it wasn't that great. Not surprisingly, because it was developed by some very smart hospital administrators and not by insurance people. Patients had their hospital stay covered for whatever services, no matter what the cost and no matter how long. That blank check did exactly what you would think it would do. Hospitals started charging more for their services. They had patients stay longer, and they offered them more services within the same package. Patients were completely blind to all of this and were reliant upon their doctor and their insurance company to simply work it out. This is another debate that continues on into modern day. How do you ensure that a patient is financially invested in their healthcare choices so they choose adequate healthcare for their needs, but you don't block them from seeking needed care just because of the cost? In other words, how do you get people to choose a white cast when a purple cast is available and they don't know whether or not a purple cast would help them or not, but stop them from not seeking casting for their broken bone at all because they are worried about the cost? But let's get back to our story. We left off in the 1930s. About a decade later, something very unexpected happened that would change the face of American health insurance forever. In 1942, the National War Labor Board, under the Stabilization Act, froze salaries in order to limit inflation. Employers that were facing a shortage of labor were desperate to find good employees to work for them. One incentive that they found that brought employees to the door was health insurance that they sponsored. And then in 1943, IRS blew on the flame by ruling that employer-sponsored health insurance could be done tax-free. And poof, just like that, the legacy of employer-sponsored health insurance in America took flight. Between 1940 and 1950, the number of insured Americans rose to 60%, and that was even before the onset of Medicare and Medicaid. Healthcare was becoming more universally available, but it still wasn't fast or convenient, and its effectiveness still left a lot to be desired. But then, in 1953, a man named Ronald Herrick sat down in front of his private doctor, put his head in his hands, I imagine, and said, "I would do anything to help my twin brother. I'd give him my own kidney if I could." And so he did. And the first successful kidney transplant took place in the United States. Healthcare was finally becoming more effective. There was an explosion of healthcare advances and technologies. Unfortunately, this was more costly for providers to offer to patients, and the individual patient's care was becoming more expensive. So onto the field came the for-profit health insurers. By 1951, Cigna and Aetna were both offering major medical plans, and the national health expenditure had reached 5% of GDP. And then, in 1965, President Johnson signed the Social Security Act, which laid the foundation for what we know of today as Medicare and Medicaid, and launched an over half-century-long, high-profile, high-emotion debate about national health in the United States. With costs increasing by the decade, people began to ask more aggressively, how can we lower costs in healthcare? Between the 1970s and 1990s, a great experiment occurred inside something called managed care. Managed care was many things on a lot of different levels and with a lot of nuances, but one thing it did at its foundation was lower choice in order to lower cost. That is, you could only see a certain subset of doctors, you could only get a certain subset of services, but because of that, you could have much lower cost healthcare. And it was successful at doing that. The problem is that the American patient found the whole concept of lowering their choice too abrasive for them to adopt this as a standard. So managed care was not as successful as many had hoped it would be. Now, unfortunately, with all of this greater complexity and the influx of more payers to the market, many providers who came into healthcare to try and help patients were finding themselves spending almost all of their energy on just trying to get paid. Practice managers became these bastions of knowledge about healthcare, in which they needed to know how to do coding, how to handle denials, how to interact with payers, how to handle eligibility, what it meant for a patient to need prior authorization across many different payers. And it was important for them to negotiate the right contracts with different payers to be in their networks so that they could get the patient traffic they needed in order to support their business model. Not surprisingly, the gap between payers and providers created a huge business, which grew over many decades. In 1996, President Clinton signed the Health Insurance Portability and Accountability Act, otherwise known as Hipaa. Most people know Hipaa because of the privacy rules, but what I think is interesting about Hipaa is that it set out a series of standard transactions for the data that's passed between payers and providers. Why is that important? Well, think about like the plumbing in your house. If the pipes could be any size and any material, it would be very difficult to have your piping fixed if you had a leak in your house. But because there are standards for how pipes are used in your household and for the materials that are used to build them, you can just go down to any Home Depot and buy a pipe that you can be pretty confident will work inside your house. You can also hire a plumber who can do the work on your house fairly cheaply and efficiently. Then, in 2010, President Obama signed the Affordable Care Act. Now, we all know the Affordable Care Act did a whole lot inside healthcare, but one of the things that I thought was most interesting was that it set out a standard for operating rules and identified an operating rules body that would define how to use the standard transactions. Great. This whole process created something that has done a lot to make healthcare more efficient. However, it's also increased the barrier for entry into healthcare. In order to do business with a healthcare payer or provider, you have to understand how to transmit data according to these transactions. So it's put a premium on the type of person who understands how to interact with all of this complexity. Now, with all of this happening in the healthcare world over the last 15 years, we've seen such a high increase in cost that it's become necessary to get the patient further engaged inside the healthcare system. We've seen healthcare insurers start to shift the payment responsibility from themselves to the patient in a greater amount. Today, patient out-of-pocket is almost 30% of the total healthcare expenditure nationwide. You've seen that in your own pocket with increased premiums, high deductible health plans, and HSAs. Employers have seen the difference because they've needed to do things like use HSA matches in professional jobs in order to attract quality employees. This change in patients accepting greater responsibility has manifested itself in many different ways. But one thing that is incredibly interesting to me is the way in which healthcare providers have always billed healthcare insurers in order to maintain their cash flow. They do so by setting a billed amount that they know is going to get reduced through electronic negotiation processes that have been established between payers and providers. Now, when providers have had to shift some of their paycheck realization to the patient, they've increased their collection efforts and increased the amount that they have engaged patients to pay upfront. You've seen much greater efforts to get paid from the patient from providers both at the time of service and after. What's interesting about that is that patients don't have electronic negotiation processes, nor do they understand that sometimes the first amount that's given to you by a hospital or a health system for the services you provided is really more of an offer that you need to negotiate. This all brings us to today's world. With the signing of MACRA, the new transparency rules, the balanced billing rules that came out in December, everything seems to be changing, particularly around patient responsibility inside healthcare and on the burden for data presentation by providers in order to show that they are providing quality care and that the care that they're offering is giving a greater value. So welcome to today. The light has been turned on. It's not dark anymore. In fact, I kind of think it's like a disco ball up in here. But many analysts, including myself, are beginning to see some little white flags all over the place that seem to be indicating that the market might be primed for transformation. But that transformation is not going to be generated or fueled by people who don't understand the complexity and history that goes into healthcare. Healthcare requires that you peel back the layers. I was told by a friend once that healthcare is like an onion, and as you peel back the layers, more layers will become available, and your desire to cry becomes a little bit more overwhelming. But that aside, I'm very excited about the future of healthcare and the precipice that we're standing on. So thank you for taking the time with me today to talk a little bit about the history of this industry that I so love and could make such a great impact on the lives of people as we change it going forward into the future.